Thank you so much to Icasa organizers for this opportunity to moderate this very, very interesting session. This session is about HIV and non-communicable diseases, and I would like to introduce you to the three panelists, the two presenters we have today. So the presenter number one is Ms. Joselyn Nakyeyune. She's from the Afya Haki Institute. Ms. Nakyeyune is a trained economist with an interest in health and human rights issues, research and documentation, open access initiatives, Creative Commons, building communities, organization development, and fundraising. She holds a master's degree in public health, bachelor's degree in development economics, a certificate on sexual and reproductive health and rights, and a certificate in project management from the University of Washington. She has over 8 years of experience in fundraising and evidence generation for health, human rights, and sexual and reproductive health and rights advocacy. Throughout her experience in civil society organizations, she has managed and directly supported the implementation of various sexual and reproductive health-related projects. So please give an applause to Madam Joselyn Nakyeyune. I hope I pronounced it well, sorry. Thank you so much. So the speaker number two is Dr. TOBLEGNON PONDE. So he's from the Santé Mentale, on ONG Espace Confiance. So Dr. Ponde TOBLEGNON is a psychological counselor specializing in career guidance and social professional integration for young people from key populations, including people living with HIV, LGBTIQ+ individuals, sex workers, and people who use drugs. With significant experience in psychosocial support, he works within the NGO Space Confiance, where he coordinates the integration of mental health and art-therapy components in the SOTRA project. So please welcome Dr. Ponde TOBLEGNON. Let's clap for him, please. And the presenter number three is Mrs. Morufat Alabi. So from the Mental Health and Psychiatric Nursing. Ms. Alabi is registered psychiatric nurse and lecturer in the Faculty of Nursing of the University of Ibadan, Nigeria. She holds a Master in Science in Mental Health Nursing with over 10 years of clinical and 6 years of teaching experience. Her research interests include mental health, psychoeducation, addiction, and HIV care. She has published on topics such as resilience in stroke survivors and burnout among mental health nurses. Ms. Alabi is also a mental health care advocate working to improve care access and understand communities. She is affiliated with Mental Health Innovation Network and Azido Foundation. So please welcome Ms. Morufat Alabi. So we will take the three presentations one by one in the exact order I mentioned the names of the presenters, and from there we will get a round of 10-15 minutes for discussions. For that round we will take first two questions round, and depending on the available time we will promote more interaction until the time for this session is expiring. So thank you so much. Let's go please with speaker number one.
Good morning. It's an absolute pleasure to be here, to be presenting this research. Thank you so much. So I'm presenting this research on depression amongst teenage mothers in a high HIV-burden municipality in Uganda. We'll be looking at the prevalence, associated factors, and coping mechanisms. That's it. All right, thank you so much. So, all right, so before I get into the introduction, allow me give a little bit of context on both teenage pregnancies and depression in Uganda. So according to the Uganda Demographic Health Survey of 2022, teenage pregnancies were estimated at about 24%, a statistic that is significantly high in comparison to global estimates of 14%. Now, there are different factors that continue to exacerbate this public health concern, including cultural practices such as early child marriages, low education levels, and of course the high risky sexual behaviors in Uganda. Now, becoming a mother while a teenager, we might all agree, contributes to different social, economic, emotional, and financial stresses that continue to exacerbate depression amongst the teenage mothers. Now, we all know that depression is one of the leading causes of mental disabilities in the world. And in Uganda, Uganda is actually ranked one of the top 6 countries in terms of depressive tendencies, especially amongst teenagers. Now, when untreated, depression can cause significant impacts in teenage mothers. It, for instance, increases the chances of repeat pregnancies between 1 to 2 years. It causes emotional distress and cognitive disabilities among children, and it also leads to suicidal tendencies. So with that context, we would all agree that depression amongst teenage mothers remains a significant public health issue. Unfortunately, it is understudied in Uganda, and this is not to say that there's not any studies. There's a lot of studies that have been done, but they've mostly focused on cancer patients, university students, refugees, neglecting teenage mothers. And also, for most of the studies, they've focused in either rural or urban areas, neglecting rapidly urbanizing areas like Kira municipality, where this study focused. So the focus or the objective of this research was to investigate the prevalence of depression, the associated factors, and the coping mechanisms amongst the teenage mothers. Next slide, please. In terms of methodology, we used a convergent parallel mixed method for this research. Quantitative data was collected from 200 teenage mothers between the ages of 16 and 19 using a structured questionnaire, which is the Beck Depression Inventory tool. On the other hand, qualitative data was gathered from focus group discussions and key informant interviews. And quantitative data was analyzed through SPSS version 26, and qualitative data underwent thematic analysis. Next slide. The findings. From our study, we established that 79% of our study participants actually had depressive tendencies. What varied was the level of severity. 27% exhibited major depressive disorders, 17% moderate, 20% borderline, and 15% mild disturbances. Next slide. In terms of associated factors, we noted that both economic and social cultural factors continued to contribute to depressive tendencies amongst teenage mothers in the study area. As you can see from the presentation, the participants gave different quotes on how they felt that these factors continued to impact on their mental health. It's important to note that while both economic and social cultural factors contributed to depression, social cultural factors were more predominant. And this could be attributed to the rapidly urbanizing area where this study was conducted, an implication that the social structures are not yet established or they are breaking. So those are some of the quotes that the study participants have had to say. I'll just pick out one in terms of the economic factors. One participant mentioned that whenever I ask for a job, or the first question that I am asked is, do you have a child? And if the response is yes, I'll never hear from the applicants again. So that really stood out. Next slide, please. In terms of the coping mechanisms, our study participants adopted both active, what we referred to as traditional mechanisms in our research, and these active mechanisms included the use of churches, use of elders, but also, and the use of elders. On the other hand, they also used non-traditional or avoidant mechanisms or strategies to manage this depression. And some of these non-traditional mechanisms included the abuse of alcohol, turning to their peers who had no experience or were ill-equipped to support them. But they also used social media, which came out very concretely as something that teenage mothers were using as a way of managing their depression. So from our research, we established that most of our study participants greatly relied on non-traditional coping mechanisms simply because they viewed them as easier to access and perceived them as available. A case in point would be the social media, which they quickly ran to. All the coping mechanisms that we assessed were assessed through the AAAQ framework to establish availability, and availability we're looking in terms of the structures, whether they're in place, accessibility in terms of distance, access in terms of information, and acceptability. We were looking at conformity to cultural values or religious values, and quality in terms of the personnel that gave the services. Our finding there was that majority of the structures or the mechanisms that the teenage mothers opted for did not in fact align to the AAAQ framework, which limited equitable access to support services. Next slide. And as I conclude, I want to leave us with something. Addressing depression amongst teenage mothers is not just a health priority. It is a lifetime for the next generation. Therefore, as we continue to program for depression amongst teenage mothers, we must adopt multi-sectoral collaboration to strengthen mental health resilience amongst teenage mothers living in high HIV burden settings. CSOs should expand community-based peer support because we see that many of the teenagers run to people they quickly relate to, and those are their peers. In terms of economic empowerment, we should ensure that this is a factor that we integrate into our support because economic factors were a major driver of depression amongst our population. And in programming for mental health, we should also leverage on non-traditional mechanisms such as social media, AI, to see how we ensure accessibility, acceptability, and availability. With this, I'd like to once again thank Icasa for giving me this opportunity, but also for Afya and Haki, which is a research organization, for this opportunity. Thank you so much.
Thank you so much, Ms. Nakyeyune. Very, very interesting research. And I think you have reminded us that, first of all, the scale of depression among adolescent mothers, especially living with HIV, is an urgent and overlooked public health crisis that we need to consider. Also, these results are, evidencing stigma, gaps in youth-friendly services and fragile social support systems that continue to undermine the resilience. So, and finally, you have also reflected during this beautiful work about the fact that adolescents are creating their own coping pathways, and but it looks like the formal system is not keeping up. So I think those are very powerful elements for discussion. So thank you so much. So we will go now with the next presenter. So please, Dr. PONDE TOBLEGNON. So please, the floor is yours.
Bonjour, chers tous. Je suis Dr. PONDE, ivoirien, et ma présentation va se faire en français. Ma présentation à Icasa 2025 porte sur le sujet qui est le suivant: santé mentale des jeunes issus des populations vulnérables en Côte d'Ivoire, l'expérience de l'ONG Espace Confiance en art-thérapie. Il faut dire qu'en Côte d'Ivoire, les jeunes issus des populations vulnérables subissent une forte stigmatisation qui est source de détresse malheureusement non prise en compte du fait d'un manque de services adaptés à leurs besoins. Et un rapport de IBBS ACSA 2016 a montré que parmi eux, plus de 45% ont déjà vécu un épisode dépressif, plus de 37% ont déjà eu des idées suicidaires et plus de 50% ont déjà une fois tenté de se suicider. Et c'est au vu de tout cela que l'ONG Espace Confiance va mettre en place un projet dénommé Sutra qui propose un accompagnement en santé mentale incluant l'art-thérapie. Donc l'objectif de cette étude, c'est d'évaluer l'apport de l'art-thérapie comme un outil complémentaire dans l'accompagnement psychosocial des jeunes vulnérables au VIH-Sida. Il faut déjà dire que les types d'études, c'est une étude rétrospective mixte, qualitative et quantitative, qui s'est déroulée dans la période de février en avril 2025. Et au cours de cette période, nous avons eu 9 ateliers d'art-thérapie en raison de 10 jeunes par séance. Et ces séances ont été réalisées dans nos différents drop-in centers. Au total, les participants, nous avons eu 90 jeunes dont l'âge varie entre 17 et 24 ans et qui ont été recommandés soit par nos assistants sociaux ou les psychologues pour des difficultés d'observance au traitement ou pour des détresses psychosociales. Il faut également aussi dire qu'une séance de l'art-thérapie se déroule en 3 étapes. Premièrement, accueil et présentation des consignes. La deuxième phase, c'est la phase de la création, où l'individu va dessiner un pan de sa vie ou dessiner ce qu'on appelle des émotions ou des ressentis. La troisième étape consiste aux échanges autour des œuvres produites. Donc, nos bénéficiaires, le participant va expliquer plus ou moins le dessin qu'il a eu à représenter. Et cela se fait sous l'encadrement d'un psychologue et d'un art-thérapeute. Et la durée tourne autour de 2h à 2h30. Et ces échanges-là seront analysés selon la thématique, selon l'approche thématique inductive. Au niveau des résultats, il faut dire que sur les 90 jeunes, 50, c'est-à-dire plus de 56%, ont été orientés vers une prise en charge approfondie ou complémentaire. Et parmi les 50 qui ont été référés, on a 35 qui, eux, ont été référés pour un seul motif de mal-être ou de souffrance majeure, tels que le désespoir, les pensées suicidaires, les conduites à risque, le stress post-traumatique, les ruptures affectives, etc. Les 15 autres ont été référés pour 2 ou plusieurs motifs de souffrance psychologique. Donc on verra qu'on a 7 qui ont été référés pour 2 motifs, 3 également pour 3 motifs de souffrance, et 5 pour 3 motifs de souffrance et 3 pour plus de 3 motifs de souffrance. À la fin de l'atelier, nous évaluons l'impact psychologique que peut avoir cette activité sur nos participants. Ainsi, un questionnaire de ressenti leur est donné pour donner plus ou moins leur ressenti. Et après ces ateliers, nous avons remarqué que 85% des participants disent avoir ressenti un soulagement émotionnel. On a également aussi 72% qui disent avoir une meilleure confiance en soi. Et enfin, 63% ont pu verbaliser pour la première fois une souffrance interne qu'ils n'avaient jamais dit à qui que ce soit. En conclusion, nous pouvons dire que la thérapie est un outil efficace Premièrement, pour identifier et repérer les jeunes en souffrance ou en détresse, favoriser l'expression et la verbalisation des souffrances invisibles, renforcer la confiance en soi et améliorer la qualité de suivi psychologique et social. Comme perspective, il serait intéressant d'intégrer l'art-thérapie dans les parcours de soins VIH et santé mentale et également aussi former les professionnels en santé mentale en art-thérapie. Donc je vais terminer par ce dessin que vous voyez qui montre un individu qui est seul au bord d'une rive, très pensif, et on voit que l'individu pense à la mort. On voit également aussi le cœur brisé qui est représenté, et juste entre les pieds de l'individu, on voit du sang. C'est-à-dire que cet individu est en réalité en train de pleurer sang. Et cela montre la souffrance interne de cet individu. Et ce dessin a été réalisé par un de nos patients qui, quand on compare sa vie personnelle, il est une personne qui a plus goût à la vie, déjà parce que perdu ses parents très tôt, et également aussi pendant le parcours de sa vie, a été infecté au VIH-Sida et se dit qu'il n'a plus rien à donner à quelqu'un et que la mort serait mieux. Et c'est grâce à la thérapie que nous avons pu déceler, nous avons pu détecter cette souffrance, cette souffrance invisible qui vraiment était ancrée à cet individu. Et aujourd'hui, je peux vous dire que pour son petit sobriquet, Tyson se porte bien. Il a été référé, il a été pris en charge par un psychologue et il suit le traitement comme il se doit. Et aujourd'hui, Tyson, je peux dire, a goût à la vie et vraiment se sent à l'aise. Donc je termine sur ces mots et je vous dis merci.
Thank you so much, Dr. Ponde, for this great presentation and letting us know more about the results of this Sutra project. Then you have stated some relevant facts, the way that antiretroviral treatment therapy spaces are providing a powerful gateway to mental health support, especially for highly stigmatized youth. This is something we need to reflect on how to increase efficiency of the public health interventions. Secondly, I think you have mentioned on the high levels of psychological suffering, revealing major gaps in youth-friendly and stigma-free mental health services. This is something also to consider. And finally, very relevant to the fact of highlighting that holistic community-based models are essential to strengthening the resilience among young people vulnerable to HIV. So thank you so much for this presentation. So we will proceed now by giving the floor to our third speaker, Ms. Morufat Alabi. So please, let's clap for her.
Good morning, everyone. My name is Morufat Alabi, and this morning I will be presenting a research work titled, titled The Effectiveness of a Nurse-Led Mobile Phone Delivered Psychoeducational Intervention on Mental Health Outcomes Among People Living with Human Immunodeficiency Virus in Southwest Nigeria. Next slide, please. These are the outline of my presentation. Next slide. By way of introduction, studies have shown that over the years, the incidence of HIV/AIDS had continued to reduce drastically in Nigeria. However, because of the stigma surrounding the diagnosis of HIV/AIDS, people living with mental health, with HIV/AIDS now have a lot of mental health issues that is affecting their well-being. These issues ranges from depression, anxiety, and suicidality. In a study conducted in Nigeria in 2017 and 2024, in Southwest, there was a prevalence of 29% and 9.7% for psychological distress among people living with HIV/AIDS. And studies have also shown that majority of these mental health issues stems from stigma and fear of disclosure about HIV infection. And as a result, even though a lot of people are adherent on antiretroviral medication, we are having a lot of mental health issues among this population. Please, next slide. Also, in this southwest Nigeria, studies have shown that most education are based on prevailing health condition, where mental health issues receive little or no attention. In most infectious disease institutes in Nigeria, there is no integration of psychoeducation in the routine care of people living with HIV/AIDS. Hence, this study's aim was to evaluate the effect of a psychoeducation on mental health outcomes among people living with HIV/AIDS in Nigeria. Next slide, please. The research method. This study made use of a quasi-experimental waitlist design, and the setting was 2 infectious disease institutes in Nigeria, Infectious Disease Institute in University College Hospital and Alabi Teaching Hospital. The target population were people living with HIV/AIDS in these 2 states, while the study population were people living with HIV/AIDS in the Infectious Disease Institutes of University College Hospital and OSUT. And the inclusion criteria were that the individual must be diagnosed of HIV infection more than 6 months, and they are above 18 years, and they must have mobile phone. While exclusion criteria was that anyone that did not disclose their status to significant other will not be enrolled, and if there are presence of other comorbid conditions or if the person is pregnant. Next slide, please. The sampling technique was a 3-stage sampling technique, and at the end of the sampling, 100 people living with HIV/AIDS were recruited in each of the IDIs. The instrument for data collection were standardized instruments. We made use of many international neuropsychiatric interview, as well as Kessler psychological distress scale. And next slide, please. The intervention itself was we adopted the intervention by Sheriff et al. In 2012, and the focus of the intervention was on the symptoms, the mode of transmission of HIV/AIDS, medication adherence, what are the things that can constitute psychological distress, and how can they cope, what are the things that they can do to cope with this distress. And part of the things we discussed were positive affirmation, how they can manage their stress, and how they can make use of cognitive restructuring to make sure that most of these mental health symptoms are ameliorated. And also, a phone call, this intervention took place for 9 weeks, in which a phone call was put across to people who were living with HIV/AIDS, and the session lasted for 15 minutes. And the session were delivered by nurses on clinic days, Mondays to Friday. Data were analyzed using Starter version 16, and analysis was through chi-square as well as mixed regression analysis. Next slide, please. From the results, you could see that at baseline, in the intervention and control group, 64% of people living with HIV/AIDS in the intervention group had psychological distress, while in the control group, 49% had psychological distress. 2 weeks post-intervention, the distress in the intervention group had decreased significantly to 13%, while that of the control group was still relatively the same as 53%. 3 months post-intervention, the distress dwindled further down to 5%, while in the control group, it still remained relatively the same at 50%. Next slide, please. Also for suicidality, in the intervention group, we had 53% prevalence of suicidality in the intervention group, while we had 44% for people in the control group. 2 weeks post-intervention, the suicidality rate had reduced drastically to 9% in the intervention group, while in the control group, it was still at 39%. 3 months post-intervention, suicidality rate in the intervention group was 4%, while in the control group still remained relatively the same. Next slide. Checking the hypothesis using mixed effect longitudinal regression, we could see that the intervention group had a higher odds of having a reduced psychological distress compared to the control group. And that means that the intervention was effective. Next slide, please. And also for suicidality, we have here that the intervention group had 3.8 lower odds of having suicidal ideation after being exposed to intervention, and the p-value was less than 0.01. Next slide, please. In conclusion, this study offers a promising evidence that a mobile phone-delivered psychoeducation administered by nurses is useful in reducing symptoms of psychological distress among people living with HIV/AIDS. It is therefore recommended that there should be integration of mental health services into the care of people living with HIV/AIDS. And also, whatever intervention that is being given should be tailored in such a way that it will meet the needs of such an individual, and it should be culturally specific. And also, further studies need to be conducted to examine how factors such as adherence to ART and duration on antiretroviral therapy, how it impacts mental health outcomes among people living with HIV/AIDS. Thank you. I would like to appreciate my mentor as well as my supervisor on this program, because this is my PhD work, which hopefully by next year I should be defending. I want to appreciate my mentor, as well as this work was supported by a D43 grant, which was headed by Professor Babafemi Taiwo. Thank you for listening.
Thank you so much, Ms. Alabi, for presenting. I think really great messages from the presentation. The first one is about that there are ways to make things under efficient approach. This experience on the LED mobile psychoeducation demonstrated to be effective, scalable, and to help to reduce the suicidality among people living with HIV. So this is something to consider, and also the role the nurses play in this intervention is something to reflect that health sector has more than their physicians. We have nurses, we have health workers, you know, we have social workers. So, you know, I think it's a strong call to also look for all the health sector staff engaged in HIV response. Psychological distress also remains as a persistent challenge, highlighting the need for sustained mental health support. So thank you for reminding this strongly. And I think finally, let's say about innovations and ways to make things different. These mobile health interventions can bridge gaps in access to psychological support, especially in resource-limited settings. So thank you so much for this presentation. I would like, before going to the Q&A section, to remind, I will take blocks of 3, and once we are done, we can go ahead with the rest ones. So we have 10 more minutes for this session for questions and answers. So I will give the floor to the colleagues here if you want to ask something or add some comment. So please go ahead. We have 10 minutes for Q&As. Who has the mics? There's one. Hello, please. We have one person. 2 persons. Yeah, but they need a mic. Could you bring a mic, please, for the ladies to ask? We have 3 questions, which Shafiq also. 4 there, okay? So, first, the lady purple dress, please.
Thank you very much to all the 3 speakers. Thank you to the last presenter from Nigeria. I just wanted to find out what informed the use of nurses for the intervention. I also wanted to find out whether the nurses that were used for the intervention group, whether you had any screening done in them to find out that they also did not have any mental health challenges themselves. And the third, I didn't hear you say what you went back to do in the other group, not the intervention group now, the other group that was used as the control, sorry, thank you, for the control group. I didn't hear you say whether you went back to do anything for them, because we know ethically there was nothing. You didn't mention whether you did anything different from what you did for them, or whether you went back to administer the same psychoeducation that you did to them. But well done. Also, I was wondering what also informed the 15 minutes. Was it based on an earlier study that was done elsewhere that found that the use of 15 minutes was in delivering the Psychoeducation Weekly gave that results that you had. Then for the first presenter that worked on for mothers, young mothers, I appreciated the fact that your study found out that mothers turn to methods like AI and all that. Did you look at what the content of what they were looking at that helped to relieve their symptoms? Was it mental health related contents that improved, that increased mental health resilience, or was it something else entirely about their reproductive health, or that improved their self-esteem? And then for the second presenter that talked about, though it was a lot more in French, but I tried to follow through, the translation broke at some point, but it was more of use of art. So I would like you to please explain more on your method. I didn't quite get that because the translation didn't come out quite good, but well done to all the three presenters. Thank you.
Thank you, madam. So because these were more like one question, so I will give the floor to all of you to reply. So then, and then we will go with the next colleagues, okay? Thank you so much. Please, you have the floor to reply. I think the mic is there.
Okay, thank you so much for that wonderful question. Yes, what actually informed the use of nurses is because in most infectious disease clinic, nurses give health education on daily basis. They always have interaction with this patient. But the education is usually based on prevailing health issues like hypertension, diabetes, and the rest. And I noticed that most of them had a lot of mental health issues, whereas education is not based on it. And in most of the IDIs, what we have there is just nurses generally. We don't have mental health nurses. So using nurses, because they are always in close contact with this patient, they see this patient from time to time. That was what informed the use of nursing. Then also, for the patients that was on the control group, like I said, I made use of a wait list. After the intervention was concluded, I still went back to those facilities to give the same intervention to them because it is ethically wrong not to give them the same intervention. Also, what informed the use of 15 minutes? In our pilot study, our goal was to have the call for 30 minutes, but in our pilot, we realized that after like 10 minutes, most of the patients were not even ready to listen. Most of them are at their place of work, even though they gave us the time to call, but it's like they were not really free to discuss. And when it is above 10 minutes, they'll be like, oh, sorry, please, can you call back? Are we done? So from the pilot, we could see that when it is more than 10, it's like the so-called intervention might not really be effective again. So when we were doing the main study, what we did was to make sure that we didn't go more than 15 minutes so that we don't bore them out with our intervention. I hope I've been able to answer the question. Thank you.
Thank you. Dr. Ponde.
OK. Donc, je réponds en français aussi. Donc, merci. Effectivement, au niveau de l'art-thérapie, nous avons étudié l'approche thématique inductive. Voilà, c'est une méthode qualitative qui permet simplement, à partir des échanges, à partir des propos participants, nous catégorisons ces propos-là dans une thématique ou dans un sujet bien précis. Donc, j'explique. C'est-à-dire que le participant qui est en train d'interpréter son dessin va peut-être dire, à travers le dessin, je me sens seul, je sais que tout le monde me rejette, ou par exemple, les gens de mon entourage m'aiment. Donc directement, la catégorisation, c'est isolement, puisque je suis seul, et également aussi tout le monde me recherche, on parlera de rejet social. Donc cette technique-là nous permet simplement d'identifier dans les propos, c'est-à-dire que les thèmes dans les propos utilisés par les participants. Et également aussi, nous avons utilisé un questionnaire de ressenti, voilà, pour évaluer l'impact que cette activité-là pouvoir avoir sur nos participants.
Thank you so much.
Thank you so much for that question. Just to respond, most of the content that the teenage mothers were looking at was not specifically on mental health. It was content that made them feel happier, more relaxed. That's why in our recommendations, we are calling up programmers to think about non-traditional coping mechanisms as an option for making information available for teenage mothers to be able to make informed decisions. Thank you.
Thank you so much. So we will continue with the questions in the order the people raise their hands. So please, there was my colleague Shafiq there from UNICEF and also a lady there, and then we go with the gentleman on that side. So please try to pick up the most relevant because we have many people that want to ask something. Thank you.
Thank you very much. I'm Shafiq Isaji from UNICEF. Congratulations to our colleague from Nigeria. Very important findings. You studied specifically this situation in the IDIs, which sound like maybe they are higher level clinics that may be better resourced than primary care settings. To what extent do you think your findings could be applicable to other types of health structures that might also be delivering HIV care?
Thank you, Shafiq.
All right, good morning.
Please go ahead.
All right, my name is Paul, I'm a biostatistician. I just want to ask the last presenter, with regards to the study that was conducted, how did you adjust for the confounders to ascertain that the results that you obtained are particularly based on the interventions that you put in place? So I want to understand how you controlled for the confounders in the study and just how you adjusted for those. Thanks.
Thank you. And I think it was a lady close to Shafiq that wanted to ask something. No, let's go then to the back, please.
Yeah, good morning. I also want to, the last presenter, I also want to find out whether, I kind of missed the location of the study, but I was wondering whether you did it in communities and whether you adjusted for clustering.
Thank you. Just want to verify because of the time, if there's someone from this side that would like to ask something just to have balance between right and left. Yes, please, the lady here, and if there's a chance, we will go back to you, okay?
Hi.
Let's go ahead because she's there, and we close with also with the lady.
Thank you. Thank you so much for this opportunity. Please permit me to sit down. My question is for the last presenter from Nigeria. So you talked about a significant reduction in the suicidal rates, right? Okay, do you have the percentage?
Okay, and final question here, please.
Okay, thank you. My name is Zara Adams. I'm a medical scientist. So my question is, the nurses she involved were just general nurses. So a research dealing with a psychological issue, don't you think it's good to involve mental nurses?
Thank you so much. So over to you, colleagues, for replying. But I think we need to take the round. Let's take this round and we'll give the floor, because if not, they will get confused. So.
Thank you so much for the beautiful question. I will start from the last question I think if I heard it correctly, you said that the people there, that is it important for us to have mental health nurses there? In the clinic, we only have nurses that are just registered nurses there. We don't have mental health practitioners or nurses working there. However, the clinic is collaborating with the Department of Mental Health in University of Ibadan to ensure that whenever they observe that there is anyone who is having symptoms of suicide or psychological distress, they refer them to our clinic. However, there is no form of education in that clinic when it comes to mental health issues. Then, sorry. Then another question that was asked was there a reduction in suicide? Yes, there was a reduction in suicide, and it was significant across the 3 time points, because we took data at baseline, 2 weeks post-intervention, and 6 weeks post-intervention. And across these 3 time points, there was a reduction in distress across these 3 time points. And when they were subjected to mixed effect logistic regression analysis, it was statistically significant. And I think I had something about adjusting for co-founders. That's why we made use of the mixed effect logistic regression, because in mixed effect logistic regression, all confounding variables, socio-demographic, were put into consideration, and this was looked into when we were analyzing our data. And I have another question that is saying that to what extent do we think our intervention is applicable to other centers? Yes, we intend to scale up this intervention because majority of people living with HIV/AIDS have mental health issues. So it's not peculiar to people who are visiting our clinic in Oyo State or Ogun State. So we intend to scale up this intervention with time. I think I've answered all the questions. If there's anything I've missed, please, you can call my attention to it. Thank you.
I think just final question, please. If there's something to add I will give the floor also to the panelists just to add something if they want, but please, final question to the gentleman.
Merci beaucoup. C'est Dr Jacques de la RDC. Je vais poser la question à notre frère qui vient de la Côte d'Ivoire. En fait, votre étude a porté sur les personnes vulnérables qui sont affectées par le VIH. La question que je me suis posée, c'est que vous avez travaillé sur leur comportement psychologique, mais étant donné que ce sont des personnes affectées, comment s'est fait cette interaction-là ou bien cette annonce entre la personne et toute la personne qui porte le VIH avec son entourage pour que vous puissiez travailler sur le comportement psychologique des personnes affectées? Qu'est-ce que je voudrais dire? Par exemple, un parent qui a le VIH, mais vous avez travaillé sur le comportement psychologique de l'enfant. Comment c'est fait que cet enfant ait connu que son père est affecté du VIH, étant donné que nous savons que pour la plupart du temps, c'est gardé assez secret, ces partages de statut sérologique qui est régi par la loi de la confidentialité. C'est de savoir comment êtes-vous arrivé à travailler sur le comportement alors que dans le soubassement, il faut d'abord qu'il y ait le partage de statut sérologique à son entourage. Merci.
J'ai l'impression que moi, mon sujet porte sur l'art-thérapie. Donc, concernant l'annonce du statut, nous n'avons pas parlé de cela dans la présentation. Au fait, ce sont des personnes qui connaissent leur statut et on le met dans ce qu'on appelle, et ces personnes malheureusement ne suivent pas bien leur traitement. Voilà, ne viennent pas au rendez-vous comme il se doit. Et voilà pourquoi on a mis en place ce qu'on appelle un accompagnement en santé mentale qui va nous permettre de détecter ces personnes-là pour non-observance au traitement et on va les orienter vers l'activité qu'on appelle la thérapie pour chercher à comprendre plus ou moins pourquoi ils ne viennent pas, peut-être ils ne suivent pas bien leur traitement et également aussi pour chercher aussi à les motiver, comprendre réellement le problème réel. Voilà, c'est un peu cela. Donc cela n'a rien à voir, mon étude n'a rien à voir avec l'annonce. Voilà.
Thank you so much, Dr. Ponde. I'm very sorry, but because of the time, so I think the 3 panelists will be available there for bilateral catch-ups with you. We need to go for the closure ceremony. So before going there, I would like to ask you to give a big applause and clap for these panelists, wonderful panelists. So thank you so much. Congratulations for all your works and keep going on research. Thank you so much, guys. So thank you so much, and let's go for the next session.